Good afternoon, ladies and gentlemen. For the benefit of those that will join us at the end of the session or those who will come in late, could we please fill up the seats at the front first and then we can allow others space when they come in during the session?
All right, and the moderator for this session is not in the room? Okay. I think in the interest of time, we'll just introduce ourselves and then present our abstracts.
Hello. Hello, good afternoon. My name is Dora Nalukenge from Makerere School of Public Health. I start? Oh.
Good afternoon, ladies and gentlemen. My name is Reste Leonina Nyonjo from Uganda, and I'm a public health specialist I'm doing consultancies with MadMay Uganda, which is an NGO working with HIV/AIDS patients, and also I have some work I do with the National TB and Leprosy Program, Ministry of Health Uganda. Thank you.
And good afternoon, everyone. I'm Jessica Gross. I'm an epidemiologist with the U.S. Centers for Disease Control and Prevention in our division of global HIV and TB in Atlanta, and I sit in our maternal and child health branch. Good to be with you guys.
So, so
All right, so thanks again for the opportunity to join today's panel. I'll be presenting on behalf of our study team the findings from an analysis evaluating the feasibility and effectiveness of HIV self-testing among children, adolescents, and young adults in Nigeria. Next slide. So HIV self-testing is a screening test, and this analysis uses oral self-testing kits, which can be used in community and facility settings. Common delivery channels include assisted, where testing is supported by a community health worker, a peer counselor, lay staff, or caregiver, as well as unassisted, where kits are given to individuals to screen themselves independently. So HIV self-testing has been used among adults to increase the demand for testing services, to reach adolescents with testing services, and increasingly among children to address barriers to testing. While used among both men and women, some interventions like MenStar have demonstrated the potential of HIV-ST to reach undiagnosed men. Next slide. So validation studies done in Kenya and Zimbabwe confirmed oral HIV-ST has a high sensitivity among children. However, the positive predictive value of HIV-ST is lower among children, given the low prevalence of HIV in this population. Thus, a reactive result requires confirmatory HIV testing to determine a child's HIV status. So this is no different than other populations, but again, because the prevalence of HIV is lower in children, some children that have a reactive screen will have a negative confirmatory test, and that's to be expected. And so that's important to include in the counseling as well. Next slide. So studies show a high acceptance of self-testing among adolescents and young people. Additional research is needed to better understand other factors affecting uptake, like assisted versus unassisted distribution channels. Additionally, emerging evidence shows high acceptability, feasibility, and effectiveness of caregiver-assisted HIV self-testing in children. And in Nigeria, there are an estimated 568,000 children, adolescents, and young adults living with HIV. Children living with HIV continue to lag behind adults on HIV treatment coverage. Next slide. So this analysis aimed to, one, evaluate the programmatic use of HIV-ST among children, adolescents, and young adults in Nigeria. Two, to describe the feasibility and effectiveness of self-testing in these populations. And three, to investigate factors associated with HIV-ST reactivity and confirmed HIV positivity to better target future self-testing programs. Next slide. So this study analyzed self-testing data from Nigeria's FASTER initiative. FASTER was a partnership between Catholic Relief Services and CHI, implemented in collaboration with the Federal Ministry of Health in Nigeria from 2020 to 2022. Sure. So data on self-testing were collected between October 2020 and September 2021 from 280 sites, both in facility and community settings across the 8 states shown here on the right, using a combination of assisted and unassisted channels. Sites were selected for programmatic implementation based on their ability to screen children 2 to 14 years, adolescents 15 to 19 years, and young adults 20 to 29 years, an unmet testing need in these age groups. Next slide. OraQuick oral kits were used since they have WHO pre-qualification for individuals greater than or equal to 2 years and federal support from the Ministry of Health. HIV-ST kits were targeted towards index contacts of PLHIV, so this includes biological children, sexual contacts, and needle-sharing partners. Also through social network referrals, as well as to clients who screened in for HIV testing using a standardized risk assessment tool. Clients with reactive HIV-ST results were referred for blood-based testing to confirm their HIV status. Next slide. Primary outcome measures included the number of HIV-ST kits used, as well as the number and proportion of results returned, reactive HIV self-tests, individuals confirmed positive, and those linked to HIV treatment across all 3 populations. Feasibility was defined by HIV-ST uptake, by population and setting, as well as the percent of HIV-ST results returned. Effectiveness was defined by the positive predictive value of the HIV-ST by population and linkage to HIV treatment. Next slide. Effectiveness was further evaluated to see if certain populations or approaches had a higher odds of being confirmed HIV positive. We investigated associations between being confirmed HIV positive and several client factors and testing approaches listed here. Next slide. So there were over 92,000 HIV-ST participants. The majority were children and adolescents 2 to 19 years, and among adults, young adults 20 to 29 years, nearly a quarter were married versus 1% of adolescents. 60% of children, 82% of adolescents, and 77% of young adults were reached through self-testing in community settings. Nearly all children received assisted HIV-ST versus 1/3 of adolescents and half of young adults. Less than 5% of participants were referred through social network approaches, and the majority of participants were first-time testers. Next slide. So over 40,000 children were tested using HIV-ST, and over 97% of HIV-ST results were returned with a 1.2% screening reactivity. 427 children were confirmed HIV positive, and over 97% were linked to treatment. The majority of children received assisted HIV-ST. 2/3 were tested in the community, yet 2/3 were identified in facility settings. 88% of children with a reactive HIV-ST went on to be confirmed HIV positive. Next slide. Assisted HIV-ST in children was an effective strategy to identify children living with HIV, especially in facility settings. Children tested for the first time were 2.8 times more likely to be confirmed HIV positive. Children tested in a health facility were 2.9 times more likely to be confirmed HIV positive. And this highlights the effectiveness of facility-based assisted HIV-ST in children, especially among those without any previous HIV testing. Next slide. So now we'll turn to the results for adolescents. Over 34,000 adolescents were tested using HIV-ST, and over 98% of self-testing results were returned with a 5.4% screening reactivity. 1,764 adolescents were confirmed positive, and over 98% were linked to HIV treatment. 2/3 of adolescents received unassisted HIV-ST with a 6.7% positivity, and over 80% of adolescents were tested and identified in community settings. Notice the confirmatory positivity is similar across settings, indicating the potential to scale the use of self-testing in facility settings for adolescents. 98% of adolescents with a reactive HIV-ST were confirmed HIV positive. Next slide. So HIV-ST was effective in identifying adolescents living with HIV across community and facility settings. Adolescents tested for the first time were 3 times more likely to be confirmed HIV positive, and adolescents were more likely to be confirmed HIV positive if they were referred through social network services, used unassisted HIV-ST, were male or married. Next slide. So now we'll turn to young adults. Over 15,000 young adults, and again, these were 20 to 29 years, were tested using HIV-ST. Over 98% returned their results with a 10.3% screening reactivity. 1,475 young adults were confirmed HIV positive, and over 98% were linked to HIV treatment. Half of young adults received unassisted HIV-ST with a 13.9% positivity. Over 3/4 of young adults were tested and identified in community settings. And 96% of young adults with a reactive test went on to be confirmed HIV positive. Both community and facility-based HIV-ST were effective among young adults. Young adults tested for the first time were 2.4 times more likely to be confirmed HIV positive, and young adults were more likely to be confirmed HIV positive if they used unassisted HIV-ST, were male, or referred through social network referrals. Among young adults, marriage was protective, as married young adults were 77% less likely to be confirmed HIV positive. So compared to other HIV testing approaches for children, so here you can see the data for, this is during the same time as the study period or the intervention period. You can see how many children were tested and identified in the positivity in outpatient settings, community settings, through index testing, and then through this HIV-ST intervention. And so compared to other HIV testing approaches for children across these 8 states in Nigeria, self-testing had a similar testing positivity to outpatient and community testing, yet may identify some CLHIV not currently reached by more traditional testing services. Next slide. Among adolescents, HIV self-testing had a higher testing positivity compared to traditional outpatient and community testing services. HIV-ST could be used to generate testing demand and better target existing HIV testing services, both in outpatient and community settings. And again, this is for older adolescents, 15 to 19. Next slide. And finally, HIV-ST among young adults performed better than traditional outpatient testing services. 3/4 of self-testing among young adults was performed in community settings, and it had a slightly higher yield than traditional community testing services. This person-centered approach to HIV testing may help address historic barriers across all 3 populations. Next slide. So given the programmatic nature of this intervention, limitations to this analysis include the lack of individual level data, detail on operational approaches, and generalizability. Next slide. So in conclusion, similar to the findings from other studies, oral HIV self-testing was highly feasible among children, adolescents, and young adults with over 90,000 screening tests conducted. There were high rates of result return irrespective of model or population. The positive predictive value was high across all 3 populations, yet slightly lower in children. The pediatric PPV, or positive predictive value, was 88%, and this was much higher in this analysis compared to assisted HIV-ST studies in children in Uganda and Zambia. Self-testing was effective among first-time testers and across both community and facility settings, with facility settings performing somewhat better among children. This intervention effectively combined assisted and unassisted self-testing models, reaching children primarily through assisted HIV-ST. Older adolescents and young adults living with HIV were more likely to be identified through unassisted channels and social network referral. Self-testing also proved extremely effective at identifying adolescent boys and young men living with HIV. So we'd like to acknowledge and thank our co-authors, especially Brianna Lee, who led this analysis during her Public Health Institute fellowship with our team, as well as colleagues from the Federal Ministry of Health, CRS in Nigeria and Baltimore, CDC in Nigeria and Atlanta, and implementing partners working to scale up the use of HIV self-testing in Nigeria. We'd also like to thank the healthcare workers and lay staff, as well as the caregivers and clients who participated in this self-testing program. Thank you.
I'm presenting an abstract titled Using the Community Awareness, Screening and Testing, Prevention and Treatment, which we termed as CAST approach for targeted tuberculosis in case finding in central Uganda. So, as we all know, timely tuberculosis diagnosis a challenge, a major challenge in central Uganda, and major patient-leveled contributors to delayed diagnosis include a lack of awareness and sensitization about TB within the communities, spiritual beliefs and myths, a lack of transport to health facilities, then consideration of other differential diagnoses for TB, such as pneumonia and TB by
the service providers, say the clinicians. Therefore, we conducted and assessed the caste approach in 8 districts in central Uganda. And why this caste approach? Uh, as you all know that in most of our countries, we have fragmented health systems whereby unmet healthcare needs, there are unmet healthcare needs because patients delay to come to our facilities. They normally come when it is really late. And also we have the increased comorbidities, comorbidity medical problems, and the one which is most rampant is the TB and HIV. And also we have symptom screening for TB and HIV testing within the community. So CAST was going to ensure that all this is handled. So now I'm explaining the CAST project design, how it was designed. First, you have to bring on board the awareness bit, because when you sensitize the communities, you tell them about the signs and symptoms of TB, and then how it presents. And if one has, they will know that, oh, I'm in trouble. I need to really be screened. So after the awareness bit, people have that information about the disease. Then you go ahead to screen whoever is available. For TB, we use the intensified case finding guide, which whereby the questions like, you have cough for how long? Do you have fevers, evening fevers? Do you have night sweats? Do you have weight loss? Once a patient has any of a yes to any of those, then they'll proceed to the next step, which is testing. For testing, for all the patients who said yes from the intensified case finding guide, these ones will be in position to give us a sputum sample such that we're able to test them. But also we go ahead to test them for HIV/AIDS. If they don't have a current documented HIV test result, we'll also do the HIV testing at the same go. And from there, that turn out to be confirmed TB cases. We provide them with TB treatment. If they are co-infected but new in care for HIV, we give them the TB treatment first, and then after the 2 weeks, we introduce the ART. But if they are already known positives on ART, we only give the TB treatment. We also go ahead to do the same day contact tracing, because this design is community. It's a community design whereby we need to also do for contact tracing for the patients, for the TB confirmed TB patients. So we also screen the contacts of the confirmed cases and give out TB preventive therapy, shortened as TPT, to either adults above 5 years or below 5 years. Then those contacts that are screen positive, we go ahead and test them for TB as well, and then the process continues like that. So these were our methods. We had a precast period, which was between 26th to 30th September of 2021, whereby we did a targeted outreach in 60 TB high burden communities. And these were, what are those? They are the markets, because they are always congested. We have the gold mines, we have the taxi parks, prisons, bars, and even some homesteads are congested, say like the slums. Then the females were they are 60%, so the remaining balance were the men, and children less than 15 years were 10%. Then the remaining balance were all adults. So the caste intervention now, this one happened in the 27th to the 30th of December of that same year of 2021, whereby we did TB community awareness, we did community radios, we did door-to-door sensitization by the village health teams, and then we distributed TB education materials, TB symptom screening for all the attendees, people who had given a talk, and then the sputum collection for those who were TB presumptive, and then also did HIV testing for that same group. And in our findings, we had both the TB cases and then the HIV positive cases. We used the unpaired t-test to compare the pre-cast period and the cast period. And the results show that when you look at the pre-cast period on that slide and the cast period, overall, there was an increase since the patient, the communities had gotten the information. Prior, there was no information given. We would just go do that test. Then the intervention which had that information, yeah, there was a positive view. The RP value was 0.039%, and it was really significant. And the next one is for the TB co-infected patients. When you look at all the districts, there are 8 districts in number. All of them show that there's a great improvement from the pre-cast period to the cast period, and still there was an increase with RP value being 0.048, which was significant. So TB cast informs us that improved TB case detection there is always improved TB case detection in targeted communities. And then it's also beneficial for TB, stroke, HIV patient identification within communities. This is who delay to really come to the facilities. And also it informs us that identification of the presumptive TB patients achieved through the efficient utilization of resources and support to the communities. In the next steps, after doing, definitely if you take a service closer to a person, they will use the service. However, we want to find out what are those cost effectiveness for CAS to happen. You have to put in a lot of some monies. So we want to to study to find out the cost effectiveness using these rigorous methods, and also to determine implementation barriers and facilitators of this CAST, and also to identify the factors influencing the adaptability and acceptability of the CAST. Implementation of CAST for Ugandan programs. Currently, as I speak now, it is a national priority activity with designed guidelines and tools. It is implemented biannually, that is in March and September every year in Uganda. It informed the Ministry of Health strategic decision to integrate key community activities. Also, demonstrated future use of community interventions while leveraging on other disease programs. As you know, there is the cost involved. So you use the existing programs to ride on. So there's malaria program, HIV, immunization, and family planning, among others. In acknowledgements, I was presenting on behalf of the team, and they're here in this room. So I acknowledge the co-authors, Dr. Alex, who is present here, and also the National TB and Leprosy team, Dr. Muzamiru. We appreciate you because that one is the CAST TB coordinator in Uganda. And then Dr. Ebony, our M&E specialist, and then the National TB and Leprosy Program Director, who is Dr. Stavia. So I also appreciate the TB stakeholders in Uganda, because to implement it, you have to work with the district teams, the health workers, the PhDs, and also I want to appreciate CDC Uganda for the funding, and then the ICASA conference for the opportunity to present to you. Thank you so much.
Okay. So I'm Dora Nelkenge, So I'm here to talk about peer-led HIV self-testing among men in Ugandan fishing communities, implementation experiences, and implications for a scale-up. So peer-led HIV self-testing has got the potential to improve HIV testing rates in unreachable men in diverse settings, including the fishing communities. However, this approach is yet to scale up to reach more fishing sites. So we described our implementation experiences in 2 rural fishing communities in Uganda in order to inform future scale up in other fishing communities in Uganda. And also this work is part of the Pest for Men study. So between May and July 2022, we implemented a Pest for Men intervention in 2 communities along the shores of Lake Victoria in Uganda. So this was a social network-based peer-to-peer intervention, of which we identified 22 males as peer leaders. We trained them, gave them oral test kits to distribute to their male members within their social networks. So after training these peer leaders, we are then asked them to refer to us 20 other men from their social networks to the study team. So they referred these men to us, screened them for eligibility. And in order for these men to be eligible for this study, they had to be 15 years of age. They had to be negative, HIV negative, or of unknown status. They have to have last tested 3 months prior to the enrollment, and they had to be referred by their peer leaders. So the eligible men, after being screened, and they had to be given 2 oral self-HIV test kits, 1 to self-test on themselves, and the second one to give to any person they would prefer, be it their sexual partners or their friends. So after being administered a baseline interview, they had 1 month, these peer leaders had 1 month to distribute these kits to their members of their social networks, because we had to go back and do a follow-up interview that was in September 2022 to determine the challenges, to determine the user, determine the use of these kits. So we computed the distributed statistics using the starter version. So if I may go into the findings, what did we find out? So of the 400 men enrolled into the study at baseline, 63% were aged between 15 years and 24 years. Then 64% had primary education as their highest level of education. Then we had 47% were engaged in fishing, all fishing-related activities. Then 90.2% of those interviewed at baseline were also interviewed at the follow-up visit. So of the 98.3 that received those that received the kits from the peer leaders, 66.0 received these kits on that very day, or the next day after that, being given the baseline interview. Then 79.7 received 2 kits, while 20.3 received only 1 kit. So 99% of these men who received these kits used them to self-test on themselves. However, there were some men who reported that they needed some additional support before or during after the self-test. Like you could see on the graph, these are the percentages of the men who needed some form of help before or during after the self-test. We had 37.2 that needed pre-test counseling, then 33.8 needed post-counseling, and there are those that needed help in interpreting the results. So there were also some common mistakes that were made between the 2 districts, because we visited Buvuma district and Kalangala district. So there are those who forgot what to do completely. They just forgot. In Buvuma and Kalangala, 15 15, there were 15 and 10, making a total of 25. Then there are those who read the results before the 20 minutes of timing. There were 14 and 7, making a total of 21. Then there are those who failed to open the package to remove the kit to self-test. There were 12 and 5, making a total of 17%. So if I can go into the experiences, almost all the peer leaders successfully distributed the kits to their social network members and trained them on how to use them to self-test on themselves. However, some peer leaders gave out only one kit instead of 2, because in the protocol they had to give out 2 kits. But some peer leaders they had a reasoning that their members were not sexually active, or they didn't need the second kit. So most of the users, that is 93 to 97%, use the kits correctly to self-test for HIV, except for some percentage, that is 3 to 7% of the men who had a few mistakes, like I showed you earlier. So you'll agree with me, in the fishing communities, money is a very big deal. So in these fishing communities, these peer leaders, they needed money to distribute these kits to their fellow members in the communities. So which was kind of not expected, but it was there. So we had to give them around $2, 2.7 per peer leader, so that we can have a successful HIV self-test kit distribution. So 2/3 of the men easily picked up the kits from their peer leaders on the first day. However, the remaining 34% required a lot of effort to reach these men. So there was some bit of impersonation as we were carrying out our study. Some peer leaders connived with the men to impose as study participants at the follow-up visit. But however, we managed to curb them, and we worked on that. So some HIV positive men lied to the study team that they were HIV negative at the start of the enrollment, the baseline enrollment, and they were given the HIV test kits as per the manufacturing guidelines. You don't have to use this kit if you're HIV positive. So what are the implications for a scale-up? It is possible to use a layperson in the community, train them about basic HIV knowledge, to distribute these test kits to social network members in the community. So it is very possible. And in the fishing community setting, where the communities are always mobile, it is possible to use a peer-to-peer model to reach a highly mobile men, using peer leaders to distribute these kits to their fellow men in the existing social networks in their communities. So there may be a need for a supervised peer-led HIV self-testing in some instances to help men who find it difficult in performing these tests, like in interpreting the results correctly. So in conclusion, our study confirms that the peer-led HIV self-testing module can successfully improve the HIV uptake among men in rural fishing communities. However, challenges in the use of these kits and interpretation of results still abound, suggesting the need for additional sensitization and potential users before the model is scaled up to other fishing communities. So in acknowledgement, I would like to acknowledge the research assistants, the peer leaders in Kasali B and Mwena fishing communities, district officials, Bustema University Faculty of Health Science, Makerere University School of Public Health, Minister of Health, and the funders, EDCTP. Thank you.
Thank you so much. I am stepping in for the lost host and co-host. And I think that it would be very unfair to let our panelists also moderate for themselves. So I would like to highlight that all panelists have spotlighted important issues from assisted to non-assisted use of self-testing kits, and to identify the cascade of how communities can be able to hold on to these interventions and make them their own, and move the whole nation and community at a time, one community at a time, to curb the health issues that they might be facing. So at this point, I would like to open it up for questions to our panelists. Yes, please. So in the interest of time, I'll only take one question, starting with the gentleman at the front, and then we can catch the panelists in the corridors and continue this discussion.
Thank you very much, and thank you for standing in for the moderator. Thank you, the panelists. Just a quick one on the CAST TB. It is such a wonderful program that has, reached many. I'm interested in integration, and you have said you have integrated malaria, HIV, immunization, family planning. How far can it go? Because we don't want to stretch it to lose its importance, but I would also want to integrate in NCDs because they are now the killers of our population. So in your opinion, is it already too stretched, or we can integrate maybe hypertension and diabetes? Thank you.
Thank you so much for that question. Actually, for CAST TB, of course, the NCDs, those are some of the most at-risk populations among the TB patients. Though it wasn't fully mentioned, but among the presumptives, we had also those that had diabetes, most especially. So I think since the national program team is on board and they are in this room, yes, it will not be too much to stretch. Yes, I think in the tools that were designed, they will be they'll be in position to also factor in the status of any presumptive TB patient, that within the screening process, we factor in someone's pre-screening for the diabetes, screening for the nutrition status, because that one is also already on board, and also screening for the hypertension. Yes, I think it will be among the parameters to look at in the review of the tools, such that we also capture it in the reporting. Thank you.
All right, thank you so very much. This discussion has highlighted the need for investment into community interventions. As we heard from Dora, there is a need for incentives, but there is also need for education to help the community members understand how to use the innovative tools that will help them diagnose themselves early enough and show up for assisted medication in time in order to save their lives. So thank you very much for participating in this session. It is a Friday afternoon, and we do understand that there is a need to, go and chill and have a lot of fun as we prepare for the weekend. Thank you very much.